السلام عليكم ورحمة الله وبركاته. نرحب بكم جميعا في لقائنا اليوم راديولوجي أنبلغ، ونخص بالترحيب ضيفنا الدكتور مصطفى الحسن، أستاذ مساعد وطبيب استشاري أشعة تشخيصية وأشعة مخ وأعصاب أطفال وكبار، الحاصل على بورد وزمالات أمريكية. وكذلك كل من المحاورين الدكتور عبد الملك أبو محسن، دكتور أشعة مقيم من مستشفى الملك فيصل التخصصي، والدكتورة فاطمة الجصاص طبيبة امتياز من جامعة الملك عبد العزيز. لقاءنا اليوم إن شاء الله حيكون عبارة عن مقابلة حيكون فيها كل من المحاورين الدكتور عبد الملك والدكتورة فاطمة بطرح أسئلة لضيفنا الدكتور مصطفى فيما يخص رحلته الدراسية والعملية وتحديات كل مرحلة.
شكرا جزيلا. السلام عليكم جميعا. أنا معكم عبد الملك. ونرحب بالدكتور مصطفى our first guest in the radiology club. عندنا عدة محاور إن شاء الله حنتناقش فيها. First, we would like to start with professional background and experience. So, doctor, can you tell us or describe your background and training in radiology as a specialty?
طيب بسم الله الرحمن الرحيم. أول شيء أرحب بكم جميعا، وأنا فخور إني أكون يعني كمان أول ضيف لكم. وصراحة يعني I saw يعني the inception of this club a few months ago. I was يعني very proud to see إنه يعني this has becoming into يعني its own club. وبعدين بعد كده يعني I see students are joining and people are getting more knowledgeable on the radiology and especially the subspecialties that are offered, the future opportunities. عشان كده anything to help radiology I'm very happy to participate in and assist إن شاء الله in any way I can. طيب أنا usually I introduce myself بدون the use of any أي ألقاب. يعني أنا ما أحب أعرف نفسي بدكتور أو أي شيء. أنا مصطفى الحسن. غالبيتكم حيكون زميلي بعد 5 أو 10 سنوات من الآن، حيكون معي في المستشفى وحيصير لي حالات، وأنا يمكن حيصير لي حالات الله أعلم. أنا استشاري أشعة مخ وأعصاب كما ذكروا لكم. Most of my training يعني was spent in the United States. جلست أنا في أمريكا لمدة 8 سنوات. طلعت في 2014. كان عندي آخر شيء أعمله اللي هو اختبار نسوي ستيب 2 CS أياميها سكيلز، وكان الاختبار أعتقد يمكن كان يوم 27 جون في 2014. طلعت وعملت الاختبار هناك. بعدين مباشرة بعدها أخذت رحلة، كان اختبار في تكساس. أخذت رحلة على نيو أورلينز and started a 1 year research fellowship training في Ochsner Clinic Foundation. Ochsner Clinic Foundation is based in Louisiana. They have I think about 11 community hospitals, one main hospital, وبعدين بعد كده 40 clinics scattered throughout Louisiana. I spent 6 years في New Orleans في Ocean Clinic Foundation. خلصت السنة الأولى في الريسيرش، بعدين بعد كده 5 years of residency training في radiology. Usually a first year في radiology throughout the US we spent either في what is called the transitional year or our preliminary year in medicine or a preliminary year in research. فإذا أنت you did a preliminary year of medicine فزيك زي ال R1 في internal medicine بتشتغلوا the same way. except إنه أنت ما حتخش في العيادات، أنت حيكون كل الشغل حقك في hospital services. So you get exposed to internal medicine. تقريبا it's like a year and a half of medicine residency crammed into 1 year. Or if you do surgery it's the same thing. يعني you will spend most of your time في the surgery departments for the first year. Or if you do a transitional year, and a transitional year يعني is usually more competitive and it is usually reserved for people يعني they didn't know what they want to do, especially المتخرجين من أمريكا. فدول الترانزيشنال years يعني بيعملوا something similar للinternship عندنا. They are doing 2 months of each specialty and they are rotating يعني في internal medicine, pediatrics, OB-GYN, general surgery, electives, etc. وبعدين بعد كده they will start their training for radiology. The training in radiology is 4 years بعد كده which started 2016 ended في 2020. So this is a total of 6 years. وبعدين بعد كده once I was done I moved to Dallas, Texas, the University of Texas Southwestern in Dallas, and I did 1 year in diagnostic neuroradiology. بعدين بعد كده followed by another year in pediatric neuroradiology. عشان كده يعني دي الطريقة I covered the entire gamut of neuroradiology, adults and pediatrics, and then after that I returned back to Saudi Arabia.
Mm-hmm.
I've been practicing as an assistant professor في جامعة طيبة and practicing as a teleradiologist in multiple hospitals throughout Saudi.
ما شاء الله. طيب, nice to know, والله doctor. One question regarding this topic. Um, is it up to you to decide whether you want an entire year in medicine or surgery prior to starting radiology training?
لا هذه you will have to apply for it separately. فلما
Mm-hmm.
تقدم على residency training in radiology, most of the spots you are applying for are called يعني PGY2. It is an advanced training. You have to also apply the programs that are offering PGY1 year
Mm-hmm.
separately. يعني كأنك انت بتقدم into two residency، واحدة 1 year for medicine ولا surgery، واحدة 4 years for radiology. or in some cases احيانا بيكون ال 5 years كلها combined موجوده عند نفس البروجرام. فهذيك الساعه يسموها categorical program، يعني عنده الفيرست year لما تقدم عليه يقول لك لا احنا خلاص if we invite you for an interview انت تحتاج تعمل also an interview with the internal medicine department because we are
Oh.
a categorical program. So if you
Mm.
apply for us تيجي تعمل انترفيو معانا، انترفيو معاهم، وبعدين بعد كده في الرانكينج لما تيجي تعمل رانكينج at the end of your شو اسمه of your interviews هتحطهم just as a single hospital. والله Ocean Clinic Foundation is a categorical program بس Ocean Clinic Foundation. لكن if you there are programs ما عندهم مثلا ال first year offer بيقول لك انت لازم تقدم هذا. فديك الساعه each advanced program ممكن تحط له في الرانكينج يعني multiple choices. يعني you might do your first year مثلا في تكساس but you will do your radiology training في شو اسمه في كاليفورنيا in
Mm-hmm.
another hospital. So يعني I think this يعني gives flexibility and the reason
Yes.
also يعني for the presence of يعني separate there is يعني the reason for separation إنه يعني it allows people to think this is really what I want to do. But then the other thing is it's not only radiology that is an advanced training. Ophthalmology is advanced training, dermatology is an advanced training, anesthesiology. So all these people have to do at least a 1 year either in surgery, either in medicine or a transition year. Usually يعني الناس اللي بتعمل more surgical they are preferred to go into a preliminary year in surgery
Mm.
rather than medicine. But يعني الناس who are doing مثلا radiology, dermatology, يعني it is preferable that they do either a transitional year or they do a first year in medicine. And then after that you will join radiology. But the
Mm-hmm.
interview season will be a single interview season in which you apply for both. And بعد كده you do your ranking وبعدين بعد كده once you get the acceptance you will get يعني the acceptance from both programs. Either you get the acceptance from both programs or you get the acceptance for a single program and you get accepted into VGY1, but unfortunately you don't get accepted into VGY2. Or you get
Mm.
accepted into VGY2 but you didn't get accepted into VGY1, and this is usually solved بحاجة يسموها SOAP تحصل بعد الماتش. And this is a bit of a complex subject.
Mm. Mm.
بس يعني this is the general idea.
Well.
كل radiologists in the United
Mm-hmm.
States they will have at least done a year in medicine or a year in surgery prior to the start of training,
Yes.
and this is يعني from their core residency training.
We'll ask more about that in a later section. I'll move to the next question, which is also interesting. That what really motivated you to pursue a career in radiology? Was it a case? Was it a certain doctor? Did you read about the specialty? How did you come to know it?
والله يعني شو اسمه there are several factors يعني I think it is a combination of factors يعني that contributed to this eventually. مثلا انا ما كنت يعني I was not يعني very interested in شو اسمه يعني spending too much time مع ال patients. Yes I
Mm.
like يعني انا احب اشوف يعني حاجات احب اشوف everything. I like to see everything يعني I
Yes.
don't want to see just a single specialty. ما بدي بس مثلا اكون خلاص في الميديسين اشوف ادرس في العياده واشوف حالات بس في الميديسين او اكون in surgery and just do surgeries. I tried surgery ما عجبني اللايف ستايل ابدا. I tried medicine, there's a lot of paperwork, في زحمه في العيادات, extending long-term care for patients. يعني you have to work with several multiple specialties, تخصصات مرجعيه. patient بيشوفك وبيشوف حق النفرولوجي وبيشوف حق الريماتولوجي. لكن الراديولوجي يعني almost encompasses everything. And at
Of
the
course.
same time, you don't have to see patients long term. Contribute to the care of the patient, but you don't see. You see everything, and almost every single patient that comes to the hospital will get some sort of imaging. A chest
Correct.
X-ray or a CT abdomen pelvis or a CT head. Almost every single patient that comes to the ER or comes to the hospital will get some sort of imaging that you will be able to contribute to.
Correct.
And the contributions from radiologists are usually meaningful and impactful. They will affect the lives of patients. You find malignancies early, you find certain diagnoses that patients have been looking for diagnosis for a year or two. This is usually very, very common to encounter radiology. So that was one of the reasons. برضه one of the reasons I think يمكن كثير منكم يعرف أو بعضكم يعرف إنه أخوي الأكبر أيمن الحسن برضه هو استشاري أشعة
ما شاء الله.
أشعة بطن وحوض و obstetrics imaging and non-vascular interventions. he contributed also somehow to me eventually choosing radiology. And I think for me the most important thing at that time was flexibility, المرونة والlifestyle. The more flexible, the more time I will have with my family.
You feel like
lifestyle
it's more of a
eventually
balanced specialty between your work and lifestyle, as you said.
بالضبط. Eventually it poured down to lifestyle. And the lifestyle for radiologists was the best out there. And the flexibility available to you is huge. There is a lot of flexibility for radiology. بعد كده التطور السريع جدا في الراديولوجي بشكل عام زي ما انتم شايفين now the teleradiology is taken over in a lot of places. Radiologists are able to contribute from the comforts of their own homes. You can contribute.
We'll get into that in a later
الجوال
section.
تبعك معلش قاطعتك.
لا تفضل دكتور. We'll get into teleradiology by the end of the interview.
and there is always a huge demand. سواء whether it is in Saudi or outside Saudi. There's always continued demand for radiology, especially for specialists, especially كمان for الناس who are well trained, who will make good diagnoses, will give out great reports, will change a lot of things for patients.
Of course. The quality of the report is really important, not just mentioning
أكيد
data.
we will come to talk about that إن شاء الله.
طيب. I think you already covered the years of experience from the first question, so I'll move to the next one. كده لو تعطينا فكرة دكتور على السريع, what was the second option other than radiology for any reason? Like if radiology didn't work for you, if you didn't get matched to radiology, what was like your plan B, your second target, let's say?
والله ما كانت في عندي كده ما كان في عندي كده certain specialty I thought I would eventually do. I always thought I will become a neurosurgeon, but then that thing changed tremendously.
Oh, interesting. You wanted to be a neurosurgeon before you considered radiology.
Yes, I wanted to be a neurosurgeon.
Well,
then I was like,
you're still reading brains and spine.
Yes,
not
I
far
read
enough.
brains, and I'm always in contact with neurosurgeons and neurologists. I work with them all the time. I'm like the middleman in between.
Yes,
this
definitely.
is what I wanted. I wanted to eventually work with neuro, work with brains, work with spines.
Neuroscience is your interest in
فكان neurosurgery initially one of the thoughts. بس بعدين that significantly shifted after I saw the lifestyle and the work hard the hard work they do. The surgeries, the amount of dedication you have to put into your work is just huge.
It's good to have you on the radiology side next.
Yes, agree.
Okay. Bye.
السلام عليكم. Good evening everyone. أتمنى أنكم بخير وطيبين. أنا اسمي فاطمة الجصاص medical intern. So, doctor, this section is going to be surrounded about clinical skills and knowledge. So the first question is, what do you think are the key qualities or skills necessary to excel as a radiologist?
طيب بالنسبة للسؤال ده يعني I think من قبل في تويتر يعني I always speak about يعني how to improve as a resident وكيف يعني improve your quality as a resident و how to excel يعني as a radiologist. من يوم ما بدأت الريزدنسي في أمريكا my goal was always إني يعني I learn as much as I can, make all my mistakes for residency, because once you make mistakes as an attending, then it is lawsuits, and after the lawsuit, after a lawsuit, after a lawsuit. And يعني almost from out of 6 radiologists, there's always one radiologist that will get sued in the United States. When I started, I wanted to make all my mistakes for residency. So whenever I was in a certain rotation, I would read the maximum amount I can get. I would read everything. Just open the list, pick up all the cases available اللي ما حد بياخدها, even the hardest ones. يعني كان الناس مثلا كنت في النيورو, they always avoided اللي هي سي تي نيك post up. كل الناس ما حد يبغى ياخذ سي تي نيك post up, which is it's a complex case and there's a lot of description into it. I was like, it doesn't matter to me. I will read it and I will learn it. ما يهم whether I make mistakes ولا أتعلم. I will make mistakes. I will be probably humiliated يعني by the staff or by the attending if I made a lot of mistakes, but I will learn.
Yeah.
Eventually I will learn, and this is what exactly happened. يعني صح كنت هزات شويه لكن تعلمت. كان الستاف اللي زي انه عارف شايفني وانت ماخذ كيس هذه اكبر منك, لكن اوكي we will teach you. يعني and this is the great thing مع الناس اللي اشتغلت معها في امريكا, يعني everyone was open to learn and يعني to teach you and take their times يعني to discuss يعني details with you. For everything single rotation I went to, I did the maximum amount of imaging I could. By the end of my training I had read يعني أكثر من 20,000, أكثر من 6,000 سي تي modality يعني ما بين البرين, abdomen, pelvis, chest. Already have read يعني over 200 PET CTs, nuclear medicine studies in general over 400. MR brains, I think I crossed 1200 or 1300, spines over 800. فخلاص by the time I was done with residency I had made most of the mistakes I wanted. بعدين بعد كده the goal from fellowship was to يعني كل هذه الميستيكس وكل هذه الاكسبيرينس I gained يعني خلاص it's time to put everything, put the puzzles together. خلاص يعني ارتب افكاري. Once I start reading an MR brain, how am I going to start and interpret it? What do I need to organize first? What diagnoses, differentials I need to consider, what differentials I need to exclude. Eventually, this is what I think eventually led me to become a good radiologist. I think one of the key important factors for any resident that who's doing residency, they should read as much as they can. Because the more you see, and the more you read, and the more you interpret, and the more reports you dictate, it will all يعني eventually end up in your benefit. يعني if you go to the hospital مثلا and read only مثلا 2 CT studies during the day, eventually ايش حتستفيد؟ nothing. You will see something else in a month and you will be يعني ما حتتذكر انت اصلا ايش قلت في الريبورت السابق حتى تقدر تبني عليه new ideas او تبني عليه يعني new ways of interpretation. Unfortunately يعني this will not eventually يعني help you as a radiologist, and also it will not contribute to your يعني accuracy and to your fast interpretation. Eventually in the residency محل ما كنا, it was a community or semi-community hospital, private hospital. Most of the radiologists are working private practice يعني تعتبر. Most of the radiologists are very fast, very accurate, very fast. They give very detailed reports. You have to become like that. They are setting you up for private practice. Academics يعني they didn't care much about academics. If you want to do research, go do research. بس انت هنا you are serving patients. You are expected to read volumes. You are expected to give out certain qualities in your reports. You are expected to help your colleagues eventually reach a good diagnosis عشان البيشنت يخرج من المستشفى مبسوط وفرحان, عشان حيرجع للمستشفى هذه بعد كده يتعالج فيها وحيقول للناس والله انا I went to this hospital and they were very good. They diagnosed me correctly. I spent يعني very small amount of time in the hospital. I would recommend this hospital to anyone to get treated there. and this is how you make money eventually برضه في الميديسن. So I think this is one of the key يعني the key skill in radiology. Read more, read more, and don't just يعني read more مش يعني بس اروح افكر كتاب واقرا، لا read more cases during the day, pick up cases, read cases, make mistakes and improve.
Okay.
That's very helpful. With your experience, how long does it take to read a CT versus an MRI?
Normal CT head 2 minutes, normal MRI brain 4 to 5 minutes, complex CT head post-op I would say يعني probably 5 minutes tops, complex brain MR depending, post GBM cases if there is perfusion or not, probably at most 10 minutes to interpret the entire study from beginning to end and to formulate an idea. I think يعني that's probably, I would say يعني 10 minutes. I think if you spend more than 10 minutes usually for very, very complex cases that you are unsure of and in cases that you don't actually have يعني, full history. But I think for complex cases, tops is 10 minutes for MR brain. Complex CT neck, I would say probably at most 12 to 13 minutes. Spines in general, and when I read even the most degenerated spine that I look at, it's like 5 minutes. Lumbar spine, thoracic or cervical. That's more than 5 minutes to interpret the entire study with dictation from beginning to end.
طبعا these numbers يعني they sound challenging for maybe junior residents or people who
They
are applying
sound
for
very
jobs.
challenging even
Yeah.
for fellows. بس
Yeah.
يعني this is يعني انت تفكر انه you will start as a resident and it will take you 30 minutes. انا هذا كان التفكير عندي في البدايه. أنا كنت اجلس جنب السينيور حقي، السينيور بي جي واي 5 وانا لسه بي جي واي 2، واقول هذا ايش شايف يا اخي؟ انت فين شايف رقم انت فاهم في نيو فارم ونرو؟ يقول هذا عمل الديكتيشن كله in 10 minutes. I was like يعني I was impressed. يعني انا اجلس اطالع اقول في نفسي والله انا ما اعرف اصلا اقرا. اقول له يا شيخ انت تعال جنبي ما اعرف اصلا المرايه، انا اصلا ما اعرف ايش شايف بالضبط. كان يقول لي يعني don't worry you are expected to make mistakes في السنه الاولى والثانيه. احنا we are not expecting anything from you. انت حتتعلم، حتتبطش هنا وهنا وهنا وحتتعلم. فبالفعل والله تعلمت يعني كويس. started بنورمالز وبعدين بعد كده يعني سيمي نورمالز وبعدين abnormals وبعدين complex cases. and then eventually I was in his seat as a PGY5 and it took me يعني like 7 minutes to interpret the entire study. بعدين بعد كده I went to fellowship. I was like 5 minutes طق 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 report is done, send it to the شو اسمه send it to the staff attending, sign it, done. فايفنشولي يعني I was interpreting ما بين 40 ل 60 studies ما بين MRI brain و MR spines during يعني a day work as a fellow من الساعة 5 من الساعة 8 للساعة 5 almost 40 to 60 on average. والحمد لله I was the fastest because يعني this is what I wanted to do always. I wanted to be the fastest and the most accurate. And يعني private practice eventually في أمريكا depends on RVUs. How much do you read? How much do you contribute? The quality of your reports. This is how you get paid eventually. فالحمد لله eventually as an attending دحين I look at studies يعني it's like doesn't take me يعني minutes to even يعني put all the puzzles together. يعني أنا أفك MRI and it is a very complex MR وتطالع فيه مثلا أنت as a resident تطالع ما انت فاهم اصلا ايش صار هنا. لكن once you become an attending تفكر الإمارة and you scroll once through it and you're like اوكي هذا البيشنت شكله عنده جي بي ام، شكله تعمل له multiple craniotomies من قبل. There is sickness from here, there is sickness from here.
start to make
and
sense.
it looks like انه it looks like what I'm looking at is a follow up and this follow up they're probably looking for recurrence of disease. Okay, and I see I already have perfusion imaging. خلاص without even looking at the history خلاص انت عندك idea because you have seen this situation يعني hundreds of
multiple times. Yeah, multiple.
عشان كده بقول لك يعني this is the most important thing for radiology. You see more, look at more studies, dictate more. لأنه eventually you're dictating also in English. English is your second language, it's not your first language.
Sure.
The better you become dictation, the faster you will become eventually, and the more يعني the more accurate your reports also will be, and they will be يعني of very very few mistakes eventually. معلش. ايش كانت النقطة الأساسية؟ كنا بنتكلم ايوه عن الوقت. ايوه فايفينشولي when you become a consultant and you have worked شو اسمه الراديولوجي يعني is a build up of experience and knowledge. You work for 8 years consecutively مع الناس اللي هم very experienced in their training. يعني الناس اللي اشتغلت معاهم مثلا في البيدياتريك راديولوجي كانوا كلهم 20 plus years of experience في البيدياتريك نيورو، واربعه منهم كلهم 20 years plus، واحد منهم 10 years plus، واحد منهم 6 years plus. فيعني they were يعني كانت ناس فطاحله تشتغل معاها. ف I always wanted to become just like them. خلاص الناس هذه المرجع. It doesn't go bigger beyond that. ف I learned from them. I continue to learn from them. بعدين بعد كده الحمد لله رجعت السعوديه، دحين الناس are learning from me، مع انه انا I feel still يعني لسه الناس اللي كنت انا معاهم these are يعني more advanced than me في التريننج. eventually يعني ان شاء الله I hope انه I become like it eventually. يعني الناس اللي اشتغل معاها from a single scroll through a study خلاص they have already formulated their idea, recommendations, differential
Yeah.
diagnosis, what is the word 1 2 3 4 في differential, what are they going to exclude, what are they going to include. خلاص they have already established the next step for the patient, what are they going to do.
Okay. Next
Okay, so
question.
the following question is, what type of intervention do neuroradiologists offer for their patients?
في a lot of non-vascular interventions. عشان نفهم النيورو راديولوجي we need to understand في حاجات are done vascular. الحاجات اللي are done vascular يعني نحن بنحط واير through an arterial axis، تمام، بنعمل thrombectomies، بنعمل aneurysm embolization، بنعمل شو اسمه stent placements etc. فهذه تعتبر it's a separate specialty called interventional neuroradiology, although it is called endovascular surgical neuroradiology. And this is a training separate done after either 1 year of diagnostic neuroradiology بعدين تعمل another year intervention neuroradiology سنة أو سنتين depending. أو إنه أنت ممكن تعمل neurology residency بعدين stroke or vascular fellowship بعدين تعمل intervention neurology and it is similar to intervention neuroradiology. أو ممكن تعمل neurosurgery residency بعدين بعد كده تعمل اللي هو endovascular surgical neuroradiology fellowship training for 1 year. فهذول mostly يعني are focusing في vascular interventions. نحن as diagnostic neuroradiologists we're doing non-vascular interventions. And non-vascular interventions everything that does not go into يعني everything that is not a wire going to ايش vessels. فايش types of procedures I was doing for the fellowship. يعني we were doing lumbar puncture procedures. وهذا يعني the most basic in neurology is lumbar puncture, myelography. This is the most basic. Insertion, chemotherapy insertion for lumbar puncture, most basic. بعدين بعد كده there is يعني more advanced stuff زي CT guided multi-level blood patches. الناس اللي بيكون عندها intracranial hypotension for whatever reason is, sometimes they have CSF leaks that may contribute to intracranial hypotension. You do a myelography, CT myelography, look at يعني every single level, thoracic or lumbar spine, but it's select several levels that you think might be the reason for the leakage for this patient, for the CSF leakage. If you identify the actual place for the CSF leakage, you can go ahead do a CT exam, another go ahead and do a CT guided blood patch at multiple levels. يعني بتوقف شو اسمه بتوقف السي سي اف leak in that place using CT guidance with يعني with different needles that we use. You inject fibrin, a mix of fibrin مع حاجة ثانية، بعدها followed by blood, and you start closing and patch these places up. هذه one of the procedures that neurologists always do. I did several kyphoplasty and vertebroplasty cases in fellowship training. These are not only done by orthopedics, neurologists do. A lot of these cases, or most of these cases, usually in hospitals in the US, I do kyphoplasty, vertebroplasty. I do spine biopsies, sacral biopsies, and biopsies in multiple areas, aspirations, and spondylodiscitis, osteomyelitis, cases. You can also do pain management, a lot of epidural spinal injections, facet injections, SI joint injections. These are all done by neuroradiologists and can also be done by MSK, musculoskeletal radiologists. These are all also considered as non-vascular interventions. There are a lot of stuff that a neuroradiologist can do, and it depends on your training. Where you train, and few places that focus more on the procedural aspects of neuroradiology than the diagnostic aspect. But eventually, you can tailor training toward something certain. And I did في الفellowship حقي the first year I did 4 months in procedures. So alhamdulillah, I've done quite a handful of procedures. And when برضه في lumbar punctures, I think by the end of residency I had done over 100 lumbar puncture. So it is the most comfortable procedure I do under fluoroscopy guidance. I think the most complex lumbar puncture takes me no longer than 10 minutes. The easiest one are usually like 2 minutes. Just put حتى even في الفلورو حط النيدل فوق البيشنت before I even start fluoro. Single fluoro image. Okay, we identify the level. خلاص mark the level. Another fluoro وحط النيدل. شوف النيدل فين انحطت. اوكي حطت في مكان كويس. Another fluoro image. Push the needle in until I reach to the spinal, almost to the ligamentous flavum. خلاص once اني حسيت بهذيك الاحساس الالمس كده لما انت تمشي through a ligament with a needle خلاص عارف انا ايش reaching the spinal canal. دف النيدل شويه. Open, check. Okay, lumbar puncture is done. Fluoroscopy time usually 0.0 seconds. You save also the patient's complications. But yes, lumbar puncture is the most basic. And في عندنا بعد كده a lot of other non-vascular interventional procedures. واتكلمنا برضو عن interventional vascular procedures. These are usually done by اللي هم اللي هم interventional neuroradiologists or interventional neurosurgeons.
That's really interesting. So, with your experience, can you discuss a particularly challenging case that you might have encountered, and can you tell us how you approached it?
بالنسبة للcases I've encountered a lot of cases صراحة ما في كده certain case that was extremely challenging. Eventually you can break everything down to radiology with images. You do a certain protocol, another protocol, you do another modality, you jump from CT to PET, jump from MR, back to CT, back to X-ray sometimes. To think about a certain case صراحة ما قد كده عدت علي complex cases عدت علي cases that that are difficult for the patient. I think I had a patient who developed this white matter, diffuse white matter volume loss and abnormalities. The white matter started turning, it started to vanish. Eventually, there is no white matter. MRI. So you look at the MRI and you don't know what is going on. And eventually, it turned out the patient has vanishing white matter disease. It's called. It is when you see it vanish, it is the name that you spell. And there is actually a diagnosis for radiology called vanishing white matter disease. And unfortunately, the patients don't do very well when they die. That patient, I think, was like 6 years old. But it all started by seeing these subtle changes with white matter. And we're not sure what is going on. Is this demyelination? Is this some sort of a tumor? But then it started progressing and eventually until everything just vanished.
Is it rare?
Yes, it is a very rare case. But when you are working في a tertiary referral hospital and I was working for Children's Hospital in Dallas, we see a lot of cases. Even the rare ones, yes, we see. How many vanishing white matter cases I've seen? I think I've seen 4 during fellowship training. Usually the rarest of stuff, if you were in the right place, you will see.
I think Dr. Kaman, the nature of radiology shows lots of challenging cases. Maybe it's hard to pick a single case.
Yes, it
There
is
are
very
many
hard to
challenging
pick.
cases. There are emergency cases. There are like
Exactly. Yani every day, yani every time I cover a shift, there's always yani some sort of a difficult or a challenging case. And yani I will eventually yani have to go in and start searching. Is this demyelination? Is this reverse? يعني even يعني كنت قبل ساعة بتمرن على الدراجة ولا أخوي الكبير بيسوي لي حالة. بالله شوف لنا الحالة هذه نيو كيس مرسلها له زميله قرأها لهم أحد الراديولوجيست outside the country. يعني they are very concerned. The kid is they have a kid I think is like 10 years old presenting with seizures preceded by multiple respiratory tract infections and fever. And they're not doing very well. They wanted to know what's going on. A radiology report, unfortunately, was very vague between encephalopathy, metabolic encephalopathy. That's why you need someone who's experienced. Look at the images and tell you what is going on. Immediately, خلاص, I collected everything together. History, the images I saw, I was like, okay, so this is how you need to approach this patient. You need to image his spine. You need to start working this patient up for demyelination. This is most likely ADM. And what you do next is do a lumbar puncture, look for aquaporin 4, do schismo oligopolar bands, do anti-mug. Anti-mug is a differential, image the entire core, see what is going on. And start treating the patient. Start IV steroids, start IVIG, and see. Probably the patient, most likely, hopefully, inshallah, they will get better. But you can see there the challenges are posed for both, for the radiologists and for the patients, and sometimes for the treating physicians.
Yes, the clinicians.
Every day you will see some sort of intimidating case. And out of the 70 sometimes cross-sectionals I read during the day, at least I have 5 to 6 cases that I will need to open up يعني شو اسمه المصادر
references
and start reading
articles
and look at differential diagnosis and could it be this or could it be that? How can I be helpful? كيف ممكن أكون helpful للphysician because this is what they want from you eventually. يعني الphysician مثلا السيرجن ما يبي يعرف منك انه البيشنت عنده bowel obstruction. يعني this is very clear. يعني I see multiple evidence هذا السيرجن يعرفها. He doesn't want to know that from you. He wants to know what is causing the obstruction. What level is the obstruction at? Is it the jejunum? Is it the proximal? Is it distal? Is it terminal ileum? Is it in the colon? Is there a mass that is causing the obstruction? Is it volvulus? Is the patient experiencing bowel ischemia? I mean, this is the details they need. They don't want to tell. They don't want from you. Most of the time, it's not just a diagnosis. They want to know what should we do next, and this is how you help. This is how radiology exactly works. It's not just a matter of أنا أجي وأرص 3 differentials كده ولا أرص له 10 differentials. No, this was never the practice of radiologists. They don't just give differentials out. No, you give them 1 differential as the most likely. You give 2 differentials as okay, probably, but then you need to tell them what should they do? What should we do next? Unfortunately, this is what I always try to keep up with. I always like to give a most likely diagnosis. I never want to give a multiple diagnosis. Do not help anyone. It can always be inflammatory, infectious, and malignant. Always. Anyone can just think of this. Even the neurologists themselves. Okay, we can say it's infectious, inflammatory, etc. I even remember a case. One of the neurologists sent me a case, MR brain for a patient presenting with multiple enhancing lesions in the brain, peripherally enhancing lesions. The radiologist who read the case, unfortunately, was very descriptive, but gave a description and that's it. But they were not sure, what should we do next? We don't know what is going on. Is this patient experiencing demyelination? Is this infectious? Is this inflammatory? They don't know. What do we do next? ما عندنا شيء ما في something helpful to do. We don't know how should we approach this. Immediately when I looked at the images, I was like, well, the degree of edema بالنسبة lesions that this patient has are just significant, which means that this is probably metastatic rather than demyelinated. rather than the maladaptive disease. I told him, okay, I will image the chest abdomen pelvis. First thing you do, image the chest abdomen pelvis. Next day, Salah, the patient is getting a CT chest abdomen pelvis. Results? Oh, numerous multiple metastatic lesions throughout the axial and appendicular skeleton. The largest is in the right sacral region. Unfortunately, he also has multiple mets for lungs, but they don't also mention the source. But unfortunately, radiologist told him, okay, there is a right-sided pleural effusion. I looked at the image, I was like, no, man, this is not a pleural effusion because it's not dependent. This is not a dependent fluid. This is more of a round, complex shape for the right side, evident by these sagittal axial reformats. This patient has a right lower mass. This is the reason. Okay. They were like, okay, biopsy. They biopsy the sacrum. Results? Oh, this is metastatic disease, squamous cell carcinoma, most likely coming from the lungs. So I was like, well, oh, this is a right lower malignancy. They were thinking, this patient has some sort of intracranial TB. So if you treated this patient for intracranial TB and you don't image him, you will not eventually benefit the patient anyway. At least the patient now knows the diagnosis. They know the diagnosis. They know how to approach this. Oncologists are seeing the patient, and the next steps are geared toward chemotherapy, etc. Whatever the stage is for the patient. So the patient now is in the right track. But now we are thinking about TB, etc.
I think what Dr. Mustafa is trying to tell everybody is try to put reports which add value to the clinician. Not
exactly.
just describe what you see. Don't tell them what
they
they know. Tell them what they don't know, so you can add value.
This is how a radiologist should work. Never be just a descriptive person. You are a clinician, clinician. You are not just a descriptor. You're not a machine. You have feelings. You want to help out. You are a physician, just like other physicians are working. You are working for the benefit of the patient. So you want the patient to get better. The way the patient will get better is by your correct interpretations, by putting him on the right track on what to do next and how to approach his case and who should he be seeing next.
I know you talked about this briefly earlier, but in your opinion, would you recommend a 1 year of internal medicine or surgery internship prior to starting radiology residency?
Yes, and I think صراحة I think everyone should be exposed generally, and they should and that exposure should be as a resident, not just as an intern. Because what happens in Saudi, it's an internship, so you're like 2 months and 2 months, and you're not really treated as a resident. You are treated as like a sub-resident. And in America, it is different. You are doing your 1 year of internal medicine, and you are acting exactly like your colleague in internal medicine residency program. زي بعض. اللهم انه هو he is doing clinics, بس انت you are doing more hospital work condensed it's like almost you're spending half of the internal medicine residency training in your first year. Then internal medicine residency training for America is 3 years. So it's like you're spending a year and a half in one. But you are exposed to every single specialty and you get first you collect all this knowledge on how physicians approach cases and why are they ordering these images. You start formulating ideas about different diseases, what they do next. My patient when they do certain images, okay, what do they do next? How are they going to treat this? What are they going to give based on the imaging they saw? How are they going to treat the patient? Are they going to give steroids? Are they going to send him to surgery? Are they going to biopsy? Not biopsy, etc. You formulate a good idea of what is going on behind the scene. You're not just jumping from med school to radiology. No, you first get to see what happens actually in the hospital, but then you go to the dark rooms and start seeing what goes in depth في management of patients. Yes, I think first year is very a year in medicine or even surgery is valuable, probably more in medicine than in surgery. So 1 year in either one, I think is very valuable for residents. And I think that's the reason why they kept it. For pathology, no, they removed it في أمريكا. It was no longer a requirement. But I think pathologists يعني يعني they are يعني they don't work directly مع ال physicians. Pathologists يعني are more of a basic science physician. It's like يعني you send them tissue. You don't send them images. No, you after you've seen the images and biopsied what you've seen in the images, and then you send them that stuff. It is, it's like it's like it's a more removed role from the role of a radiologist. If we say عندك physician بعدين بعد كده عندك radiologist. After the radiologist you have the pathologist. The pathologists are more removed from the clinical daily work in comparison to the radiologists who are working at the same time or working close proximity مع الناس في الميديسين والسيرجري والبيدياتريكس سواء في emergency settings or for routine settings, etc.
Okay. And we're halfway through the presentation. We still have some to cover. Moving to the next section, Doctor, how do you stay updated with the latest advancements in radiology? Do you depend more on articles, or do you go to conferences, whether physically or virtually? What's your way of being an updated new radiologist?
Read articles, search online, refer to your mentors, show them cases, see cases.
MashaAllah, you still refer cases to your mentors, although you are a consultant currently.
Yes, yes, I have tough cases that I see, and I still send them to, and I still get the opinion of my consultants اللي كانوا في أمريكا. And that's what they did يعني we always had an interesting case conference weekly. في كان كل consultant يجيب الكيسز تبعه and they discuss the cases together. They were يعني حتى لما كنا نقرأ during the day كده فجأة يرسل الكيس للconsultant الثاني مع إنه هو is covering something else just to get his opinion. And I think يعني that is something beneficial for the patient. Eventually we all want the benefit to be for the patient. ما في أحد كده عنده والله I am the know it all. ما في.
Yes.
This and I hate this. And بالعكس I love to get the opinion of experienced radiologists, radiologists who are much better than me, because this will also help you gear your level of knowledge and your training. It is something to look up to. Eventually, you want to become someone like this. You want to approach cases the way they approach it. So you see the ways of approach. You see how they think of it, because كل واحد تفكيره يختلف when they approach the case from attending a difference. But you get their opinion in combination with your opinion. Eventually, this will be very beneficial for the patient and also beneficial for you to become eventually better and better and better.
Okay. طيب, are there any emerging technologies or techniques in radiology that excite you? What's coming next in the brain imaging?
I think what is coming next is 7 Tesla MR for focal cortical dysplasia. Functional MR is already there. Use of DTI. We are unfortunately the use of advanced imaging ما عندنا as much. Even perfusion imaging حتى أحيانا even in big hospitals I have to tell them يا جماعة in every report I reckon all GBM cases should get a perfusion imaging, and perfusion imaging is considered the basic of advanced neuroradiology. And there are a lot of advanced radiologists in America and that I work with and they were promising, and I thought eventually it will change a lot for radiology. I know people are thinking طب ليش مش AI artificial intelligence. I worked with artificial intelligence في أمريكا. كان في عندنا program اسمه AI Doc. It was a great program. I like it. You get from the ED مثلا 5-6 stat CT heads at once, and it's like every CT head depending على radiologist. في radiologist it will take him 5 minutes to interpret, but في واحد ثاني بطيء it will take him 10-12 minutes to interpret a single CT head. But if there is an emergency CT head, one of them and that gets read the last, that's an issue. AI doc was very helpful. طلع لك what he thinks is more, and it's most likely the stat one that you need to read first, because he's thinking انه والله there's probably subdural hemorrhage هنا, and there's probably epidural hemorrhage هنا, فيطلع لك في الليسته and this is the most pressing CT head you need to interpret. And you open it and you start interpreting it. I think artificial intelligence is great in making us better and in making us faster. صح, it will not interpret for you anything. It will just be like, oh, several pixels هنا شكلها hemorrhage. And then you open up the case and you start reading it. Sometimes it's like, oh, these are just basal ganglia calcifications. And then you will have to say it. What AI doc has identified as an area of hemorrhage is actually basal ganglia calcifications, not a hemorrhage. So you have to disagree with the report for the benefit of the developers eventually to identify areas to avoid an AI eventually.
Okay.
So I think artificial intelligence is very helpful. It will be very helpful for radiologists in general eventually down the road. It will not replace you. There's no way انك تحط certain image وحيجيك ال AI يكتب لك التقرير كامل من البدايه للنهايه. This just does not happens انت في مخيلتك في مخيله الناس فقط. You have to integrate a lot of stuff. Radiologist does not just look at images. The radiologist looking at your history, your laboratory investigations, what happened في last imaging, what happened في other imagings, في الام ار اي حقك اللي عملته قبل سنه، الام ار اي اللي عملته قبل 5 سنوات, what has changed since then, and then your current imaging and what is it showing. You are combining several things into one. This kind of communication can only be done by humans. Machines will not be able to generate a similar interaction. To
simply saying machines don't have insight such as humans
yes. وبعدين لو نيجي نشوف داك has missed a lot of stuff من اندو ليكس. وكان قبل كم اسبوع كان في واحد من الراديولوجيست مطلع الاي داك في نقطه كده برا اللنج soft tissue density كانت برا اللنج, الله اعلم ايش هي كانت, وطلع لنا اللنج نار. It's like
oh, I thought it was a lung nodule.
Yeah, it was AI is thinking it's a lung nodule. It is outside the lung.
It's outside the lungs already.
It's outside the patient.
Ectopic lung nodule.
Whoever follows the radiology في Twitter حيشوفها. Yes, AI will be very helpful, but it will not replace radiologists. أي واحد يقول لك AI will replace radiologists. This guy just has a general idea. He's thinking إنه AI, the way AI works, نجيب كده صور وأحطها وخلاص هو يقول لي إيش صار. And he thinks إنه a radiologist, they're just generating diagnosis and that's it. هذه limitations of his thinking. فعشان كده أي واحد يقول لك أنتوا الراديولوجي الAI حيستبدلكم. يا عم خليك ساكت, انت اصلا تعرف كيف تشتغل راديولوجيست؟ ما يعرف. انت يمكن راديولوجي ما تعرف الجست اكس راي, حتى even if you give a chest x-ray you don't know how to interpret.
Okay, so the next topic is going to be about collaboration and communication. So the question is, how important do you think it is to have meetings with other physicians to discuss difficult cases from any kind of specialty?
Extremely important. ما كنت في fellowship as a fellow I was running an ENT conference. بيجيبوا كل الحالات حقتهم, احنا ندخل 20 إلى 30 حالة. نبدأ من الساعة 7 إلى 6:30 الصباح. لا معلش, من الساعة 7 إلى الساعة 8:30 الصباح نبدأ نشوف كل الحالات تبعهم, نشوفها على different modalities, CT, MRI شو اسمه وPET. And they always had certain questions for the radiologist. This recurrence, هذا كان hot هنا ما هو hot. هنا كان في avid uptake ما في avid uptake. هنا كان في ميتس ولا ما في. هنا كان في involvement beyond the clostridial sulcus ولا ما كان في. الاكستنشن هنا في أي منطقة. How many lymph nodes, أي levels, etc. فالinteraction is run by the radiologist, and ENT surgeons will always have numerous questions for you, especially كمان في install based and برضه they are joining ENT. We were also running weekly conference مع حقين الtumor and neurosurgeons. All the cases, all the GBM cases, all the gliomas, pediatric الحالة, pediatric الحالة. كل الادلت كيسز حقت المالجنسيز كلها بنشوفها together. السيجر كيسز كلها لها كونفرنس خاص بيها. في focal cortical dysplasia والله كان tumor is a reason for seizures etc. يعني في تيومر بورد في بورد في كونفرنس ميتنج خاص بيهم. and they are meeting also مع النيوروفيسيولوجيست والنيوروساينتست وبيجوا ناس حقين السيج يعني كان it was a very complex conference. Even
I
the
would like
functional
to ask sorry. And said I would like to ask an additional question if you don't mind.
Go ahead.
How do they usually these meetings and interaction go? Do you discuss findings, differential diagnosis,
Yes, we discuss
management plan?
findings in the imaging, differential diagnosis, what is the likely diagnosis, and what is the recommendation, what is the next step recommendation from the radiologist. بعد كده they are discussing together اللي هم clinicians based on what you have said, based on what tissue has shown and pathology if they biopsied something, and then they will come to conclusion. Oh, do we need additional imaging? Do we need to image something else? How long do we need to follow this patient? What should we do next? Does the patient need PET CT? Does the patient need to get a lumbar puncture, etc. But there is always some sort of question posed by the clinicians. في pediatric neuroradiology كنا نعمل every day كان في conference في الصباح مع النيورولوجيست مع النيورولوجي تيم نشوف كل الكيسز تبع النيورو والبيدياتريكس اللي admitted سواء النيورو اللي قبل ولا overnight. We are looking at all the images we have currently for the patients. برضه كان في pediatric neuro oncology conference separately, pediatric seizures conference separately. You are working with almost every single specialty and even subspecialty. في ناس مثلا متخصصة skull based tumors انت you are meeting مع ناس بس skull based. بس this is sort of لما تكون مثلا في advanced hospital زي في امريكا. I don't know كيف في التخصص فيهم. Do they have small teams that are very very subspecialized? I don't know. بس مثلا احنا كنا في محل ما كنت انا اشتغل في تكساس ساوث ويسترن النيورو راديولوجيست كان في تقريبا عندنا 22 او 23 نيورو راديولوجيست في السيرفيس. سكال بيز نيورو سيرجنز كانوا يمكن 4 أو 5 شو اسمه نيورو سيرجنز اللي كانوا يعملوا tumor cases كانوا برضه 4 5. You have huge teams, huge subspecialized teams, huge numbers. عشان كده interacting مع deep subspecialties in your practice. I think that we are not having just general conferences. حتى في الريزدنسي مثلا حتى الCT thoracic surgeons كنا نتقابل معاهم في كونفرنس مدة ساعة مع كل thoracic surgeons. طبعا الثوراسيك surgeons هذول بس اللي بيشتغلوا على اللنجز. بعدين في السيرجنز اللي بيشتغلوا على البريستس هذول كمان لهم كونفرنس لحالهم اللي هم بريست سيرجنز. فهذول كمان كنا بنتقابل معاهم differently. وحتى الجنرال سيرجنز depends هذا الجنرال سيرجن هيباتوبيلياري ولا الباش هذا ولا كولوريكتال. الكولوريكتال لهم ميتنج لحالهم والهيباتوبيلياري كمان لهم ميتنج لحالهم. ف yes you are interacting with every single one.
Interesting.
In King Faisal, Dr. Mustafa, we do have such meetings. يعني مثلا HCC, hepatocellular carcinoma cases, they do discuss resection, local chemotherapy.
هذه كانوا دائما يعملوها كثير عندنا حكي intervention radiology. What do they want to do next? Y90? Should we embolize again?
Exactly.
Is the lesion smaller now to get the patient for resection ready, etc. Yes, that was also something.
Just for the sake of time, I'm gonna move to the important or let's say most important questions, which focuses on ethical and professional challenges. So I'm gonna just give two scenarios. For example, let's say there is a rare case that was diagnosed through imaging. A radiologist mentioned the right diagnosis, and later on, we found out that this case was published by the primary team without informing the radiologist, which was the one who initially diagnosed the case. And this is not a rare scenario. It happens from time to time. It happens with radiologists. It happens even with pathologists. They also diagnose different diseases through tissue. What's your opinion about that? How can we approach?
والله يعني شوف I've never experienced something like this while
Mm,
working in the US because يعني
mm,
it is all about integrity. You
mm,
have to have integrity as a physician. Whenever even يعني the smallest of case reports or even the general case reports that they have written, whenever
mm-hmm,
يعني there is a case just for يعني, and they just wanted some imaging. Oh, we just want to يعني to look at the images and يعني write us some write about the findings and write شو اسمه some details about it. They included your name and your contribution is very minimal. But it all depends يعني على the integrity of the author of that article. يعني they should always include the radiologist, the pathologist, يعني whoever was the reason for the case يعني eventually be
and
broken down
vice
and
versa.
diagnosed.
And even if the radiologist wants to like publish a rare type of
Yes
tumor,
يعني نحن we never publish something بدون ما نرجع للتيم يعني اصلا
exactly.
مين كان ماسك الحاله؟ والله الحاله كانت عند الفيزيت. طيب مين كان البرايمري اتندنج؟ هو
Mm.
داخل نحن نروح نتكلم مع الدكتور والله نحن بنكتب شو اسمه كيس ريبورت اباوت الحاله هذه اللي شفتها and we will يعني we like to include you معانا في الحاله. sometimes شو اسمه يعني it also depends على السيتويشن تبع الكيس. مثلا كان في حاله مثلا شو اسمه اتذكر في الراديولوجي كانت مرت علينا حاله بس البيشنت يعني they were born they got imaged MR with MR and then unfortunately they died the next day because of a very rare syndrome. I think yes كانت Lissencephaly syndrome. يعني ما كان في significant contribution from any team. فالراديولوجيست يعني they just wrote this case يعني نحن كتبناها بنفسنا لانه يعني ما كان في يعني داعي to include anyone else. ما
Mm-hmm.
في كان في significant contribution. But when there is a significant contribution to the care of a patient and that patient يعني was under a certain service for a while or attending that attending يعني should always be
That's that's the problem. The only contribution that the radiologist did is diagnosing the case itself.
yes but
But
that is the significant
yeah.
contribution. عارف
Mm.
that's a huge contribution because
Yeah.
without him you wouldn't have done يعني anything. Probably and the patient would have been يعني.
So this is also a very sensitive scenario. For example, we have a resident who missed, let's say, an unstable cervical spine fracture, and unfortunately, it resulted in patient compromise. What's your
Depends
opinion about
يعني
this? For example, like in an on-call setting, like it's 3 a.m., 4 a.m. In the morning, the consultant is probably not in the hospital. The resident, he might have a senior resident with him. Some cases they don't. And these findings, these outcomes, they might happen, يعني.
unfortunately يعني this happens هنا. It happens يعني maybe often or يعني from time to time you will see it and depends على level of training and confidence في الريزدنت يعني. Unfortunately you should not expect much من الناس اللي هم لساعة هم في first or second year of training and you should not expect يعني a lot. and they should have يعني supervision. فمثلا احنا انا كنت اشتغل في امريكا في residency we always had night hawks working overnight. كان في 5 overlapping night hawks 1 week on 1 week off خلص اسبوع اللي بعدهم. we always had an attending doing either teleradiology or they were working from on site or they were working from home. You read the case, you sign the case immediately to them. They see the case, they agree with you, they sign over you وخلاص ينزل فايل الريبورت انتهى ما في مراجعه في الصباح ولا شيء. تيجي الصباح لسه جديده كل شيء من جديد. فيعني الاوتبوت كان was very quick لانه اوفر نايت يعني as a resident انت you are reading تقريبا 30 40 سي تي تقرا ما بين 10 الى 15 ام ار اي so there is no time even to read x-rays ما تقدر تقرا x-rays خلاص يعني
That's true.
the service is too busy. but you need an attending also at the same time. مو معقول انت تجي الصباح وعندك 40 سي تي وعندك 15 ام ار اي. this will take you the entire day ما حتخلص. عشان كده كان في عندنا نايت هوك سيستم. طبعا هذا كان بس من المين كامبس يعني ما بالك طب الكوميونتي هوسبيتالز الثانيه قديش بتعمل. عشان كده كان في عندنا 5 اوفر ماركت راديولوجيست تو كفر اللي هي تقريبا 12 مستشفى كانت في اوشن. والاوفرلابنج راديولوجيست from different experiences، ناس body fellowship، ناس radiologists، ناس كانوا NSK. ف immediately when you get something very complex طخ بطقه واحده انت ممكن ترسل ستدي للثاني المتخصص ويشوفها ويعطيك الانتاج
That's really
حقه،
top
or
top.
or he will take it over ويقراها.
Yes,
نحن we have unfortunately not reached to that level of complexity. And no one
that's
wants
top
to
quality.
know.
To get a validated report by 4 a.m. That's top
بالضبط.
radiology quality يعني.
And in order to reach that quality you have to pay. معلش يعني you have to pay. يعني الناس هذه ترى اللي يشتغل one night he is making يعني كانوا بيشتغلوا 10 ساعات تقريبا، and one night after taxes كل شيء بيطلع له زي $2000. this is اسمه 7500 ريال تقريبا، 8000 ريال شيء زي كذا. طبعا لما تكون تعتمد كمان اي نايت، يعني نايت during the day ولا نايت during the weekend ولا هي نايت في فيكيشن تايم، كريسماس داي، كريسماس، هذه كلها لها تسعيره.
I think
فكانوا
everybody would love to see Night Hawks inshallah in our hospital.
ان شاء الله. And this is eventually how the practice should move. You should
Yes.
have attendings covering evenings من الساعة 4 العصر إلى الساعة 12 and attending covering من 12 للساعة 8. And
The
you
thing
should
is,
pay. You should
the
pay
thing
them
is,
well.
doctor,
And these are يعني these are difficult times to cover.
the thing is, hospitals do have covering fellow on-calls and consultants. They do have them in 24-hour, but sometimes, you know, the resident is reluctant to pick up the phone and call the fellow or the consultant, especially when it's late at night.
Yes, لأنه يعني
Just to ask
unfortunately
him about a query, equivocal, could be something, could be not.
مو هي هذه المشكله، انه يعني تولد عندهم كذا الخوف انه الحين اتصل على الكونسلتنت وبعدين يهزئني يقول لي انت ليش متصل علي على هذا الشيء اللي ما له داعي وليش بتزعجني في الليل. فيعني وانفورشنتلي كمان هي part of it is يعني من الكونسلتنت نفسهم، يعني they've given يعني that vibe and this eventually يعني will need to change. ان شاء الله it will change eventually.
Okay.
Yes, I think يعني the next step for radiology, Nighthawk system. Eventually for big hospitals they will need and they will eventually cave in. This is the next step from there for them. لأنه خلاص السيرفيس of radiology eventually will become a 24-hour service. أنا محل ما كنت في residency we were doing routine images من الساعة 5:30 الصباح إلى الساعة 10 الليل. الام ار اي شغال. انت تشتغل الام ار اي يعني انت مو معقوله جايب لي ام ار اي ب 10 مليون تدفع عليه 600,000 في السنه عشان صيانه ما بتشغله. يعني you are losing money انت you are doing only 10 cases. This is crazy. يعني what are you doing؟ الناس في امريكا لا يا حبيبي هذا الام ار اي انا جبته انا مطلع منه في اخر اليوم 70 80 مريض كلهم they're getting image في الام ار اي ده، انا مطلع دبل الفلوس حقتي. ويروح يشتري بعد ايه خلصت السنه يروح يجيب واحد ثالث. يعني احنا كان في يوتي ساوث ويسترن 11 ام ار اي. تخيل اجي الصباح انا لسه اوريدي في 80 ام ار نيورو. ابوي انت ايش بتسوي؟ لا والله هذا بس تصور اللي عملنا لهم يجي من الساعه 8 للساعه 5 بس سيم تايم من الساعه 8 للساعه 10 معليش من الساعه 5 للساعه 10 بعد ما 5 بس سيم تايم انت عندك كمان ايش؟ يو هاير مور بيبل. More people are benefiting. You are creating jobs for people. You are making money and you are creating jobs. دائما الراديولوجي دائما anywhere في امريكا الراديولوجي was covering يعني their cost and other specialties. في other specialties they are not covering their cost. Radiology was covering because يعني they were generating most of the income for hospitals. عندك مثلا تيجي الصباح yes there are 10 new radiologists خلاص they are leaving the list list is moving. And then you have also patients coming in during the day. في الصباح كل ال 11 MRI شغالة. MRI never stops. I always, even for residency, I was reading MRs from inpatients overnight. يجي الطوارئ فجأة الساعة 12 الليل MRA head neck brain عادي usual brain tumor. دوبه صارت الساعة 10 الصباح 10 الليل صارت الكيس CT head oh there is a big intratracheal mass. 10 ونص مخلص الام ار اي with intravenous contrast و ام ار اي دان ام ار بي وام ار اي وهيك. الساعه 11 اوريدي فاينل ريبورت من الراديولوجيست خلاص نازل في السيستم ومنتهي. البيشنت الصباح النيورو سيرجن يشوف الحاله خلاص everything is done. يلا نكست ستيب خذ البيشنت على ليش؟ على ال على ال على شو اسمه على الاوار. ما في ديلي اوف كير there is no delay of care خلاص continuity of care اول باول.
Okay.
Okay, I'll be asking a couple of questions about academics. So I'm a medical intern, and tomorrow on Sunday is going to be my first day in radiology elective. So my question is, how can interns and students make the best out of their rotation in radiology?
شو اسمه، انا لما انا كاتندنج صراحه، انا الستودنتس والانترنز الانترستد اقول لهم يعني لا تجوا مره بدري، تو بي اونست.
Really?
ليش؟ لانه الريزدنت نفسه هو دوبه ما هو عارف ايش شايف، فهو عمال يشوف الحاله ويفهم ايش صاير، ما هو محصل الوقت عشان يقول لك شوف هنا في كذا وفي كذا وفي كذا. فلا اقول لهم
But
انت تعال كده على الساعه 8 ونص 9 تعال، عشان خلاص اوريدي الريزدنت ايش هاز ميد هيز ايديا اباوت ذا كيس، يقوم بعدين تجي توصل يبدا هو يشرح لك. هي شوف كان في كذا فلانيه كذا فيها كذا كذا فلانيه فيها كذا 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 كذا. بعدين بعد كده يجي التندنج عاده 9 ونص الى 10 يلا they start reviewing the case. عاده زي كذا كانت تقريبا في امريكا. هنا عاده اعتقد بيجوا زي كده على الساعه 1 على الساعه 11 11 ونص، وبعدين بيجون ثاني مره الساعه 2 ونص على 3. لكن احنا تقريبا every an hour and a half معلش every 1 hour and a half 2 hours الاثنين بيعدوا ثاني مره and at the same time يعني they are looking at the cases في الستيشن تبعهم or they are looking at other cases that they are reading from themselves. فبقول لهم زي كذا تعالوا على ذا الوقت عشان يبدا يورون، لانه في الراديولوجي you need someone to show you stuff. يعني you're not just going to learn it by reading a book. No, this does not happen. does not happen ان انا افك كتاب واقرا واجي خلاص انا عارف الشيء. لا، you need someone to show you and this is يعني what a lot of attending يعني have taught me. this is what I do مع الناس اللي هم الستودنتس، جيبه وتعال اجلس جنبي شوف هذا كذا هذا كذا هذا كذا هذا هنا نحن هنا شايفين هذا ما شايف ده هذا الشيء سوفت دنسيتي، ليش هذه سوفت دنسيتي؟ ليش هذا كارسل دنسيتي؟ ليش هذا كذا؟ ليش هذا كذا؟ هذا شايف هذا المالجنسي شوف جي بي ام هذه محلها هنا، فين محلها بالضبط في البراين؟ مش خلينا نشوفها على 3 دي ايمجز، خلينا نشوفها على الاكزيال كورنر ساجتال، خلينا نشوف الاريا في الباط، خلينا نشوف سيجنال. تعال شوف هذا دي دبليو اي، هذه اي دي سي، وهذه بوست كونتراست ايمج. وليش هذه بوست كونتراست ايمج وهذه بري كونتراست ايمج؟ فاي بريك يعني radiology down to them to the basics and I don't expect you to know anything ولا شيء، ما يهمني. I don't care.
oh,
You know it or you don't know. Okay, if you know it, fine, great. But I don't care. What I want you to do is sit with me, look at the cases, learn a few stuff, understand how the physicians are thinking, how radiologists are approaching the case, understand why we are ordering another imaging, why we are ordering certain lab investigations, why we are ordering MR, why we are referring the patient to the medicine, etc. وبعدين بعد كده خلاص بعد الساعة واحدة I don't care if you stay you leave doesn't matter. أهم شيء أنت you came and you got the benefit. إذا جلست بعد الساعة واحدة I will probably give you الديكتيشن حقي الميكروفون أقول لك يلا خمسة أعمل ديكتيشن. ولما تعمل ديكتيشن ما حقول لك أنت بس شو اسمه يعني أتصرف، لا حاجز جنبك أقول لك يلا قول كده، قول لانج فوليومز are normal symmetric. ليش قلنا لانج فوليومز؟ قول كده يعني بالضبط. أنا زي كده
this will
اتدربت.
definitely build
انا
some
كده انا
confidence.
كده في امريكا زي كده اتدربت، كنت اجلس جنبه ويقول لي يلا قول ليجامنت فلايم هايبرتروفي شو اسمه هنا في ليجامنت فلايم هايبرتروفي ذير از مودريت تراسايدو فلايم ناروينج. ليش في هنا مودريت تراسايدو فلايم ناروينج؟ عشان المودريت فلايم. وهنا في الليفت سايد يس ذير از مارك، قول ذير از مارك ليفت سايد فلايم ناروينج. سبايكاستينوسيس ذير از مارك باستينوسيس. يلا الليفل اللي بعده هنا في ديفيوز ديسبال، شايف هذا ديفيوز ديسبال، يلا قول ذير از ديفيوز ديسبال. اوه بس استنى هنا في سوبر امبوز بروتروجن. ليش سوبر امبوز بروتروجن؟ انه يس انه في ديفيوز ديسبارس بس برضه في بروتروجن ات ذا سيم تايم. فهذا البروتروجن فين محله؟ سب ارتيكولار لا هذا البروتروجن شكله فرامل. يلا قول كده قول there is mild diffuse discharge with superimposed left paracentral protrusion. استنى ما قلنا هو سمول مودريت ولا large. هذا شكله سمول، خلينا نحسبه حسبناه. اوكي يلا قول سمول زي كده this is how I would teach you radiology. قول
okay,
كده.
so how can sorry. So how can interns and students make a good first impression in the radiology elective to residents and consultants? Do they need to come prepared during the modality they're covering the week
يعني
prior?
شو يعني احضر اجلس معاهم اسال استفسر جماعه ايش شايفين هنا؟ ليش هذا كذا؟ اتكلم present something choose a topic and present it. اجلس معاهم احضر معاهم في الحالات في النقاشات. اهم شيء اللي هي النقاشات اللي تحصل على الفيو بوكس، ستيشن اسمه فيو بوكس، هذا اهم شيء. الفيو بوكس يعني is the best time for learning for radiology. يعني انت بتشوف الكيسز لايف مع الاttending, the way he is interpreting it, the way he's looking at it. and even انا when I was sitting في الفيو بوكس كان الاttending بيفك على طول الديكتيشن تبعي، بس بيعدل، حتى انا بسمع وبشوف هو ايش بيعدل بالضبط وايش بيقول، ليش بيقول كذا، ويقول لي شوف انا هعدل كذا واعدل كذا واعدل كذا واقول كذا، فعشان انا كمان اتعلم، عشان اعرف انا ايش اقول في الريبورت تبعي eventually. خلاص زي كذا this is how we learn radiology.
Well, I think, doctor, the challenging part, which I see for many interns, is that they don't know what to do during the rotation. Yani if you're in the ER,
Exactly.
if you're in pediatrics, you probably know you are assigned to two patients. You're gonna go
Exactly.
take vital signs.
فانت
But
you need to find a good resident, find a good
yes,
resident or find
exactly.
a good consultant, someone who is willing to teach. This is
Interested, صح. Interested
yes,
to teach you and to guide you.
someone
يعني.
who is interested, who is willing to teach you.
And
ليش؟
I think it's
لانه الاشكاليه انه
mm,
كثير من الراديولوجيست يعني شوفوا يا اخي الستودنت هذول بياخذوا روتيشن بس عشان يجي في الهواء يمشي، فما يعرف انت انترستد ما انت انترستد، ما يعرف. لكن لما يجيني والله انا ستودنت يقول له دكتور انا انترستد جدا, I want to become a radiologist, I want to know من جد because this is يعني something I would like to consider, اقول له طيب ابشر هي تعال, انا I don't overwork it. بالعكس كذا تعال تعال الساعه 9 ولا تخاف, ما حجلسك, انا ما حخليك تقعد بعد الساعه 12. I know this is radiology, انت you want an easy rotation, انا عارف انت بتركض السنه كلها هذه حقه فوق في البيديا في الميديسن في السيرجري حقه فوق, لا ما حقه. I know you want يعني to learn something, you know you may want to join radiology, or even if you don't want to join radiology, but at least you get يعني some benefit from your presence here. تعال من الساعة 9, تعال الساعة تعال مو مشكلة, تعال 9 ونص, أنا أقول له يعني I expect the resident will be done by 9 ونص, تعال 9 ونص أنا حكون موجود معهم على 10, من 9 ونص إلى 10 هم بيوروك الكيسات تبعهم, من 10 إلى 11 أنا بشوف الكيسات معاهم, بعدين بعد كده أخذهم معاهم الكونفرنس الساعة 1 إلى الساعة من الساعة 12 الساعة 1, طيب كده توكل الله على بالك. إذا أنت you are really interested in dictating cases, yes تعال تفضل أنا حاعطيك الديكتيشن حقي وهعلمك. You will open up chest X-rays and you will start dictating chest X-rays because this is the most basic thing يعني to learn في and this is how I would approach it as an attendant. أنا متأكد يعني أن every senior resident or a junior resident will have their own way of teaching and interns, showing them cases and showing them يعني basic stuff. Still يعني as a first year resident you can show them يعني general stuff في الchest X-ray, في الchest imaging, في abdominal imaging, appendicitis, توريهم hemorrhage في البرين, epidural, intracranial hemorrhages, subarachnoid, توريهم شوية aneurysms. فيعني there was always يعني some method of teaching, and this is how radiology works. teaching في radiology زي كده يعني it is by experience, يعني كأنه نحن عندنا الرأس, وبعدين من الرأس كل واحد بيعلم اللي تحت, يعلم اللي تحت, يعلم اللي تحت, to the most الى اللي هو البيزك او الفيرست انتري ليفل intern في السيرفيس.
I remember, doctor, once I had a student who was really interested in radiology to a degree that he attended an on-call with me, full-time on-call, and he was actually the one receiving the calls. يعني طبعا I was sitting next to him, but he was يعني so motivated to read images with me, to يعني go to the ultrasound room and see the patient and try to grab the probe and do his examination. I think,
كويس.
yeah, and you can show your interest in radiology in many ways. I think the most
Yes.
important part is just to understand how we operate, how we think, how we talk, and how we act. يعني don't be in a hurry and rush to understand the knowledge of radiology, but how we practice it. I think, yeah,
ايوه
I agree.
بالضبط. والله
طيب.
طولنا نحن شويه هنا.
I'm
انا
just gonna move to the
يعني
last section for the sake of time. Can you tell us quickly, Doctor, about the importance in use of teleradiology in both primary and tertiary healthcare centers?
this will be a huge topic. let's do يعني let's
طيب.
reserve this for another meeting.
Any thoughts for the future of teleradiology in Saudi Arabia?
We will answer this when we come out in future meeting. This will يعني هذا topic is very important. We will need to discuss it separately. It will take us at least يعني half an hour to speak about it, speak about the opportunities سواء locally or internationally. And there are huge opportunities يعني that are coming to Saudi. Teleradiology practice evolved radiology toward more flexibility.
Sure. Inshallah, we would like to have you, of course, in a
بس
future
عشان I
event.
wasn't expecting to go this far. I also have services to cover, and I have studies also to read.
Of course. طيب, can we take at least just one or two questions from the chat box? Let's see. Someone is asking, I think he's asking which is better for stroke, a CT scan or an MRI?
No, you do CT because this is the easiest thing available. And it is widely available in every single hospital. MRI is expensive and it might not be available in every single hospital, والشيء الثاني MRI شو اسمه has certain protocols to get through patient metal, etc. This will delay the care of the patient, and MRI will take probably في البروتوكولز اللي موجوده عندنا happen. Even لما كنت في امريكا كان عندنا بروتوكول اسمه go brain is like 5 minutes, 5 sequences. It was very quick, but still the availability of MRI is not as CT. CT has like 30 seconds in the scan and you're done. You will immediately be able to see if the patient is experiencing acute stroke versus subacute stroke versus chronic or mild stroke or no signs of stroke. And that and to the neurologist شيء مهم انه يعرفوا في hemorrhage ولا ما في hemorrhage. No hemorrhage خلاص administer شو اسمه administer altiplays thrombolytics, administer thrombolytics based على ناتشيشن سكور حقه حق المريض, وبعدين بعد كده we will see extent of the stroke on MRI. But the basic thing, yes.
I think what you're saying is that don't jump for MRI. Do CT first and take it from there.
Yes.
If we're
CT
approaching a
بعد
stroke
كده,
case. Okay.
بعد كده they will do an MRI. You will get the MRI then. That's CT first.
Fine. Thank you so much, Doctor, for this interview. We're really honored to have you as our first guest in the Radiology Club. It was really nice talk. You shared a lot with us, and we hope to have you, inshallah, in future events. Would you like to say anything to the attendants here
ان شاء
today?
الله اتمنى لكم جميعا التوفيق. ان شاء الله انكم سمعتوا كلام كويس عن الرياضه. Unfortunately الوقت تعرفين كيف صغير, وان شاء الله we will aim for another meeting to talk about teleradiology services, to talk about كمان questions تبعكم. اتمنى انكم تحتفظوا بكل questions عشان نجاوبكم عليها. واللي يحضر منكم ان شاء الله ال 14th annual Radiological Society meeting في الرياض. Meet my friend Fabrizio Coltrane, very nice neuroradiologist الصراحه. Southwestern assistant professor, Jacob in Brazil. So if you see him there, meet up with him, talk to him. He's extremely knowledgeable, very great guy all around. اسمه Fabrizio Coltrane.
Inshallah, we'll say hello to him and we'll say إنك تسلم عليه برضه. This is just a reminder that we have the conference, the RSSA conference will be held in Riyadh, inshallah, from 14 to 16 of December. So if you're a radiologist, a technologist, or someone who's interested in radiology in general, we would like to see you there, inshallah. That's it for today. Thank you, Dr. Mustafa. Thank you, Fatma. Thank you, everybody, for your attendance. Inshallah, we'll meet in future event. Thanks a lot, everybody.
ان شاء الله. شكرا لكم جميعا. مع السلامه.
شكرا. مع السلامة.